everyone. Welcome back. We're really excited to have a really special guest here today with us. I'm Amar Ahmed. I'm a partner at Wilmslow Health Centre.
I'm Fari Ahmed. I'm another partner at Wilmslow Health Centre, and we're talking to Dom Pimenta today. And he's going to...
Dom, introduce yourself.
Oh, saying hello. Sorry, I didn't want to interrupt you.
No.
Hi, I'm Dr. Dom Pimenta. I'm a cardiologist, internal medicine physician, AI academic, but more lately, the CEO and co-founder of a company called Tortus. And thanks very much for having me on your podcast.
No, very welcome. We're really excited to have you here, and thanks for this product, which I think is absolutely amazing. So we're doing this showcase of OSLER, which is their AI product for consulting rooms. The reason we're doing it is actually, in primary care, we do 90% of the consultations in the NHS. And I think that this is essential technology that needs to be funded by the NHS and put into every consulting room as quickly as possible. So we just want to showcase this to make sure everyone's aware of it. And then every GP in the land needs to take it to their manager and say, actually, that £3 billion the Chancellor announced for AI, we need some of it. So that's what we're doing it for.
Yeah. Try and stop the big boys from taking all the money like they do. What were they going to spend all their high-tech money on? We found out today.
Was it spare Da Vinci robots?
Yeah, and don't forget, they're going to that very modern technology.
Yes, we went to a meeting today and they were talking about just voice transcription.
And they were excited about it. They were like, oh,
this is a hospital.
Voice transcription now. And we're like, oh.
Yeah, anyway, mustn't digress. Okay, so one of the first things that everyone asks about is this product secure? What's the security like? And are they able to use it in the NHS?
Yes. Sorry, you lagged out a little bit there. So that made me sound like suspicious. Tortus was actually, I think, the first company in this category of generative AI embedded intelligence to get the DTAC, so the assurance criteria from the NHS itself, which covers within it a bunch of security and compliance pieces. So it's CREST approved, pen tested, it's like the cybersecurity approvals. It comes with what we call a DCB 160, which is like a clinical safety risk assessment of all healthcare IT, and all of your healthcare IT systems at home will have that, and it matches all those criteria. And it's compliant from a data protection point of view. So it's GDPR compliant, and all our server cloud systems are all hosted here in the UK. And I think just to add a layer of on top of that, we don't actually keep any data. We don't keep it. It doesn't persist in the app. We don't keep it in the cloud. It's a desktop app that's installed, and then so you can keep some local data, but when you close the app, it also gets deleted. And the reason we did that is actually, as a company, A, we don't use data ourselves. We don't build or train our own models, so we have no need for it. And B, because we have no need for it, then keeping it is just a compliance and security risk. So we deliberately got rid of that. But that's allowed us to move very, very fast. So we can constantly change the models. And what we do is clinically evaluate the models in our stack. And currently there's a whole bunch of different models in there at the moment. It's all combined together. But I think we're now on our 6th speech-to-text model, and that's an upgrade from last week, funnily enough. And we're also on a 6th large language model now as well. And we have some other different types of AI in the back, which is doing things like coding and stuff like that. But the ability to move very fast at a time when things are moving very, very fast, and with assurances for the end user. So from your perspective, it just gets faster and better. But from ours, we're doing a constant evaluation on the back end. So that's actually the kind of advantage of not keeping that data, which is why, we've been super
secure.
Yeah. Exactly. Thank you.
Yeah.
I think that's quite reassuring, isn't it?
Absolutely, very much so. So can I just get this clear? So you're not actually training it in any way. It's not using any of our information or our consulting audio to train the model.
No, and in a funny way, isn't that amazing, right? Isn't it amazing that the models today have so much knowledge encoded in them on the speech-to-text side and the large language model side, that you can do what we call instruction fine-tuning, which is all in the prompt, essentially, and we do lots of guardrailing and very careful around how that works, and spend a lot of time developing systems of clinical evaluation. We have a whole platform of 100 clinicians now that looks manually at all of our outputs, so tells us that we're doing the right things and we're doing it in a safe way. But the fundamental point is there's so much clinical knowledge encoded in some of the GPT models, Opus, and some of the new, even some of the new open source models, that they can do clinical tasks to a very, very high degree of quality, sometimes outperforming humans. And I've seen some of their data say we're nearly there with the same performance of human scribes as AI scribes now, without any specific training at all. And that actually means that, you don't need to worry about data provenance, at least at this point.
Right. Okay. Well, let's get on with it. Do you want to show us what you can do?
Yes, and in fact, I'll show you something I didn't show you last time. So these are our microphones. We give them to both the doctor and the patient. They're really snazzy. They just sort of sit on here and hook them up here. So you get actual good hardware. And it's really key, actually, for this type of system that the hardware is very good. We spent a very long time finding the right hardware systems. And I'll show you what that looks like now. So let me share my screen.
So I've been using the normal webcam that I've been using through COVID for my consultations, my video consultations. It seems to work okay. Yeah,
I think that's the thing, isn't it, though? What you really want to do is to create a system where, you wear this and you don't have to worry. You don't have to worry if, a bird flies in the window or there's 5 people in the room or you're in a very noisy environment. These are designed for vlogging. My team are going to make fun of me now. They're designed for vlogging, not vlogging. So they're noise cancelling, and they actually have a 200-meter range. So the other advantage here is that you may be talking in front of your computer and GP, but actually if you talk over by the exam area or you talking to a parent or patient somewhere else outside of the vicinity, you're not going to capture that. So it's just a peace of mind. The other thing, actually, they come in a pair. So here's the other one. And sometimes the patients really like to wear them, because what's your biggest fear when you go to the doctor? That they're not going to listen to you. And it's this type of technology, I think, that actually patients really engage with, funnily enough.
But it does mean at the beginning of the consultation, we need to fit them up with a microphone as soon as they enter.
No, I mean, you wear one, and generally what some of our users have been doing is just leaving the microphone on the edge of the desk. But if it's a small room, you only need one, and you can keep the other as like to constantly charge, and you can cycle. The base unit is a bit like a pair of earpods, so you can just cycle them. And if you get an annual license, you get that, so it's great. Very cool. Okay, so here is OSLER, which stands for Operating System Leverage Electronic Records. It's a desktop app, so it's installed on the system, and that's super important because you can do some extra stuff with that, which is super useful. But why don't we do a consultation and just show off what it can do. So, Amma or Farid, do you want to be the patient or the doctor?
Oh, after you.
Oh, okay. Shall I be the patient then? Oh dear.
Very good. You can be the patient. Great. Okay, so I'll say, hi, Farid. Welcome back to my clinic. How can I help?
Well, I think I'm going through the menopause. I have all these symptoms. I can't remember anything. I'm very tired. My hair's falling out. I've got no energy. My sleep's awful. My mood is down.
Okay. Yeah. And any hot flushes or any types of those symptoms?
I'm not sure. I think I might do. I think I have episodes where they happen, but it's not like a hot flush where I go red and everything stops. I'm just a bit more aware of the temperature, but it's not like what you read about. So I don't know for sure.
Okay. And any other symptoms at all? Any breathlessness, chest pain, palpitations?
No, those are all okay.
She's definitely a bit more irritable these days, Doctor.
I also have a non-supportive husband who I've brought along with me. But
I'm sorry to get the point, but unfortunately they are all non-supportive. That is a feature, not a bug. Sorry, I got distracted with that. Yeah, so, okay, and, how are your periods at the moment? Are they regular? Are they...
So they're regular, but they're getting more and more spaced out.
Okay.
Yeah.
And how spaced out now?
So every 2 to 3 months. They're not as predictable as they were. So.
Okay, no problem at all. And tell me about your past medical history. Anything, medical conditions, anything else like that?
So when I was younger, I had my appendix removed. I think that was when I went to secondary school. I don't know how long ago that was. Was that
50 years ago?
As I said, a very supportive husband. So maybe about 20, 30 years ago. Yeah, and then I've had 2 children. And I don't think I've had anything else. Have I a supportive husband?
No, I think you've been quite healthy.
Thank you.
Very good. Obviously, very supportive husband. And any medicines that you're taking, either for this or for anything else?
So I've tried evening primrose oil, and I've tried some stuff from the pharmacy. I think it's called menopause care, but it hasn't really made a difference.
Okay, no problem. And are you allergic to anything?
Nothing that I know of. Although I did see a program by Davina, and it was great. She talked about these hormones that they give you life back. So that would be what I'd be really interested in, Doctor.
Oh yes, okay. Well, we can talk about that. Do you smoke?
No.
And do you drink alcohol?
Occasionally.
And what do you do for a living?
I'm a housemaker, homemaker. Yeah, with a supportive husband. Sometimes.
Intermittent. And anything run in the family at all? Any history of early menopause? Any history of any ovarian problems? Anything like that?
Not really. I think my grandmother might have had breast cancer. And I think one of my uncles may have had a blood clot, but I think he was a smoker. Yeah, I think that's it.
Okay, no problem at all. Well, I'm just going to examine you now. So also the patient's well at rest. Heart rate is 90. Blood pressure is 152 on 90, so a little bit hypertensive. And the temperature today in clinic is 37.7. And respiratory rate is 20. Saturations of mirror 98%. Cardiovascular examination, heart sounds 1 + 2 + 0. And respiratory examination is all normal. There's mild thyroid swelling, about 1 to 2 centimeters in the midline. There's no peripheral edema. There's no abdominal striae. Abdominal examination is normal. Bowel sounds are normal. Okay. Well, I'm not really sure what's going on. I think the best thing to do is start off with some blood tests. We'll see how that goes. We should also do a pregnancy test. I know it's a bit unusual.
That'll be a miracle, Doctor.
No, can't do that.
Stranger things have happened, but I think it's important as well just to rule out the obvious things, and then we can take it from there. Does that sound okay?
Yes, that sounds like a good place to start. Thank you.
So, end of the consultation, you can also add some dictation, which you'd often use. So, for example, I said, let's do some blood tests, but I didn't specify what they were. So we do recommend that you just sort of speak out any additional information. So, okay, blood test for the next patient, full blood count, iron studies, thyroid function, morning cortisol, and full hormonal panel, beta HCG, and then we'll see how that transpires. So once you finish, you hit I finish consultation, then you'll start transcribing, and you'll see that the transcription is extremely fast.
Wow.
So let's have a look.
Good.
It's pretty good. It's nearly instant.
Waiting for the summary.
Menopause, hair falling out.
There you go, summary.
Oh, is the summary there?
Yep.
And then go straight to the summary. So the summary is available. Here we go.
That's
brilliant.
Very quick, isn't it?
About 5
Yeah.
seconds.
Yeah.
Menopause, presenting complaint, possible menopause, memory issues, fatigue, hair loss, allergy, poor sleep, low mood, irregular periods, past medical history, appendectomy to childbirth, even primrose oil. So it's pretty much called it.
It got you.
Diagnosed and coded. Quaff target. Is your husband supportive or not? That's really funny. It caught the thyroid, 1 to 2 centimeters, no proof of edema, possible menopause, blood test including, and then that's the bit that I dictated there at the end. If you see that there, more follow up on test results. And then say I want to refer you on to my endocrinology colleagues. So I say, hope this consultant that finds you ready, visits my clinic, patient past medical history, appendectomy 30 years ago. Like better than any letter I've ever written, I have to say.
Yeah.
Consultation. I think this is the really interesting thing, isn't it? Like, look at this, I forgot all of this. You said you told me that your grandmother had breast cancer, uncle had a blood clot, does not smoke. It's got the examination findings in there very nicely. It's corrected out a lot of my silly things, beta HCG. And then also, so we're doing a bit of patient comms. So at the end here, you've got some notes of the patient. So explanations of what menopause is, appendectomy is, evening primrose oil, thyroid, blood test, beta HCG. We've got some codes. This is set up for secondary care, but
Excellent.
this is ICD coding. So non-toxic goiter, unspecified, menopause.
Does it do SNOMED at all?
Yeah, so we are doing SNOMED now. And interestingly,
Brilliant.
we're prioritizing the QOF codes, but obviously, as you guys know, right, the QOF codes are, it's more than just getting suggestions. You have to get them right with the business logic. So there's an extra element of business logic, but the actual codes seem pretty good. There's only about 75,000 coiffed toes specifically. And then features we're sort of bringing online now. So got some templates in here. You'll soon be able to add your own templates, so you can switch.
So that's Gosh's Great Ormond Street. Just to mention to everyone that you're actually used at Great Ormond Street.
Yeah, that's right. And yeah, I can't talk any more about that because I have to go and get comms approval.
Yeah.
But you know, we've done some bits and bobs with them. And it's just to show you that there's a soap note here in a different format. And the idea is that you'll be able to give your own style and template and then just have your own system set up. And then at the moment it's copy and paste. We're working on integration, shouldn't be too long now, with a third party for EMIS integration. So you just push the notes back in.
System one?
So yeah, same, sorry. It's
System
the same
one.
API. So System 1 and or PPP.
And some of the newer ones as well, I hope, because we're moving from those two. Yeah,
we're having early discussions with the new players as well. I think it's a very interesting time in the market. Medicus and those guys. And then the other thing that you can do, so if you have like Surgery Connect or any of those telephony providers, you can just get the audio file after your console, and you can just drag it and drop it onto the system. So saves you having to do some of our users, like when they do speakerphones and stuff, have to and it's already done, so it's super quick. You should like try to record it through a speakerphone, but now you can just drop the file straight on there, and that's the sort of advantage of being on the desktop. And you can see that the summary is back again in about 5 seconds. So
very good.
Yeah, that's where we are. What are your questions?
I think that was great. It's really quick.
It's certainly a lot faster than the one where we trialed on our head-to-head. So that's really good. It's improving all the time. It's British. It's got all of those kite marks and reassurances for us as clinicians that our data is going to be safe. And it's.
I think the coding is actually, because that's one of the things that we were talking about is like we're counted. Codes are how we get counted, and that's how we get paid. So if we can get the coding in and recorded, that would be really helpful.
Absolutely. Yeah. So Dom, what would be your elevator pitch to a jobbing GP for your product?
Do you want to go home early?
Yeah, very good.
But I say that, but that is the reality. Like some of our GP colleagues that have been using this for a while.
Dave Triska.
Yeah, it's Dave Triska, exactly. So he's now.
Dave Triska's an IT legend, by the way, everyone. So if he says it's good, it's good.
Yeah,
absolutely.
It's on our website now. But I mean, that's the reality, isn't it? I think there's lots of ways to pitch it. You could talk about, better cost capture and more efficiency with patients. But I think the reality is the job is really, really hard. And the goal here is to make the job easier and enjoyable again. So you're not spending the 8-9 minutes or whatever with the patient typing. There's lots of the lift of, composing referral letters on the fly, all of that cognitive load. Whereas editing something that's, highly accurate and curated for your workflow is obviously always going to be much lighter in that sense. And then you get huge, time savings as a consequence. And then the idea that you can make many business cases out of that, your locum cost and clinician engagement. But I think more fundamentally is like, as you said, right, 90% of all consults are in primary care. We're really not giving the tools to the people that really need
Absolutely.
it. Yeah. And we as a company are all about what we're called Tortus, right? So we're going slow and steady with introducing AI. We thought we'd find some of the simplest use cases and just really, really make them much, much better as fast as we can. So I guess my elevator pitch is like, here's a team of 17 clinicians, machine learning scientists and engineers, and quite a lot of money from various investors who are just there to make your life better. And what can we do together, I think? Because really, as you see, right, you told us last week it was too slow. Now it's basically, I don't know, faster.
Moving really fast.
That was impressive, wasn't it? How long did that take? How many days?
Yeah, well, it's funny. It's just timing, right? We've been cooking that for quite a while, but but it's the natural way this will all go.
And I've noticed that the structure's a little bit better as well. So it's a huge improvement, and it's good in the first place. So what does the future hold for you? What kind of things are you looking at next?
Yeah, so roadmap is, integration to primary care. I think that's something that people ask. So that comes with codes that make things life a lot easier. Beyond that, we're looking at the downstream tasks as well. So ordering your bloods for you, doing your ERS referrals, doing your prescriptions, or at least teeing them up. I think there's an element of tech and there's an element of compliance. And I'm a clinical safety officer. I'm actually one of 4 now in the company. So this is the stuff that we take super seriously. So we'll do that super slowly. But I think like taking away more and more. We've got some dictation coming. We've realized it's essentially at this speed, it also works really well as just dictation. So, you know, point and click, put your cursor somewhere and you can just dictate letters and notes and we'll have that very, very quickly. I think the future in general is super interesting. So our goal as a company is to, first of all, liberate clinicians from their computers. You go back to just doing the human piece of work, which, you know, we've done for 200 years. There's this weird blip where we lived inside computers for like 10 years. And then hopefully the rest of, you know, medical history is very much human to human contact again. So that boils down to information gathering from the system. So we'll start looking at how to summarize and answer telecom questions like when did the patient last visit the cardiologist and what was the last troponin, et cetera, et cetera.
So we'll actually suggest those questions to you when you're with the patient, or?
Well, you can just ask and say, what is it? What is that?
Okay.
I mean, that's the goal. I'm not saying we have to get this yet, but that's the
would it be feasible, you know, I've got a patient in front of me, I'm seeing quite a few a day. It's not feasible for me to read through all the notes every time or read through the horrible summaries that we get on EMIS. So, you know, as I'm talking to a patient, taking a history, prompts coming up saying, look, actually, this patient had a cancer a few years ago, those kind of things.
Yeah, so like, I mean, the initial use case is actually just to pull the problem list out and present it back to you and then combine it with the notes. So it's much a richer note and it updates the problems, which is the issue with coding. You have to have input and output. So we'll have problems coming out of it quite soon. I think it's much richer to look at sort of document management, looking through letters like that. Because that's obviously another huge burden and we may have
massive burden
development in the document management space. And the documentation you've seen, so capturing, but also like the quick documentation that, you know, your Accurix messages, your emails, your little tasks, those kind of snippets of tech. And then, you know, the downstream actions and eventually potentially even like going to fill out your e-portfolio and you know, some of those PDP stuff as well. But I think level 2 is where I get super excited as a physician, because once, you know, in 2 years' time, let's say, you know, your podcast is watched by every GP in the country, and they're all
already is.
I mean, it will happen, right? Best one ever. But like, working alongside AI is going to be a fundamental shift in how we practice as clinicians, and it's super exciting because at that point you can start adding clinical decision support, diagnostics, what's the latest guidelines here, what's the waiting time at the local A&E. That's like operational knowledge, right? That's not a medical device, that's just useful. And we've kind of seen this already, like with the templates, you can nudge behavior in a way that we haven't been able to before, because the part of these resistance is to have a templated output. We saw this when we were doing some testing. We saw, you know, physios and dietitians who don't often ask about allergies, but the template was set up for clinicians, so it had an allergies section which was just blank. After 2 or 3 test consults, they started asking about allergies because they were annoyed that it kept saying not mentioned. They weren't being tidied, it was just the output of the LLM. But like, that's a really good example of how we can make care much safer and more consistent. Very little lift on the AI side and no human effort, which I think is probably the key. I think, you know, receptionist triage is a really good use case for that. Just a bunch of templates, they're on the phone, it's populating. Oh, I've forgotten 2 things. Don't have to train them anymore because basically the LLM is supporting to ask the right questions in a consistent way. You know, just close all the little gaps where patients get lost. I think that's the key part of decision support. I mean, in the long term, you know, we could talk all sorts of, you know, things, but I think that's the goal for the next couple of years for sure.
Brilliant. That's looking really good. Dom, remind us of the price again, because I think we got the price wrong on our review. I think things have come down in price.
Well, yeah, so if you buy an annual license, you get a pair of these microphones, and we'll come and do lots of implementation and onboarding with you. And then it's £79 per full-time user per month. So for a sort of surgery cost, we'll work out your sessions. It's like 10 sessions is considered full-time use. And then that's the annual fee. We have a monthly fee. It's a lot more because there's no fixed cost because we have spin up clusters. We do actually now also have a pricing for if you buy 20 licenses altogether. So that's sort of at a PCN level. And that's a little bit cheaper than that in terms of per head. But yeah, that's where we are.
What we're talking about there? I'll put it in the details in the video.
Yeah, I mean,
Let's get it
it
on the
depends
spot.
really.
Yeah.
Like if we're talking like if you want to buy, you know, because realistic some discussions are 100 seats, you know, across
Yeah.
you know, across an entire PCN,
Yeah.
then that's a question for us. And we look more even at
Fine.
sometimes we have an enterprise model as well, which is usage based.
Yeah.
So that's like a certain number of hours across an entire setting, and that's.
But these prices we're talking about, these are peanuts for the NHS.
Yeah.
And the amount of productivity, the bangs for your bucks you're going to get for that is huge, in my opinion.
Yeah, and I mean, like, you know, primary care is facing lots of pressures, and that's one of the things we were actually talking about is people are going to have to make redundancies and things to survive. But actually, if you can use this to save on your cost, on your time, then it would be great.
And mental health.
Well, yeah. I don't know what we'll say GP's mental health, but let's go there. So can people share it? So if you buy like one full-time license, can you get 2 users or 3 users part-time on that?
No, so well, the reason we say no is actually not because of pricing at all, but because we have so much customization. So, you know, you put your style into it, you put your templates, you put your custom vocabulary, you fill in your license and your signature. So like it's very unique and you don't want to shift. But what we do is we say, okay, you have 1 full-time sessional GP, 2 part-time sessional GPs, it's X number of sessions. If that costs, you know, a fraction of whatever that is. And then that's the monthly price for the surgery. And if you want to add users or take users away, then, well, you can't take users away because it's annual license. But if you want to add users, then we just add additional seats. I mean, it works very similar to most enterprise SaaS in that respect. We can add a user, you know, with NHS.net email in about 2 minutes. So it's a very simple process. And in terms of like, you know, getting hold of it, go on the website, sign up to our waitlist and book a demo, and then we'll send you a contract and you do the data sharing agreement. And anyone can try it free as much as they want for a month. And I think it really is something that you need to try and see if it fits. Like, I know you guys love it, you know, and we love you for loving it, but it is something that takes a bit of getting used to. And there's also a bit of like, you know, there's a few different hurdles in terms of when people are ready to adopt. Some people are already using it now and they love it. And some people are very much still waiting to see, I think, like what how this falls and how this comes apart. And I think that's really important.
Brilliant. Dom, thank you so much for your time, and thanks so much for showing all our viewers what OSLER can do. Any questions?
No, I think it looks very exciting.
Yeah, and we'll keep in touch, and any updates, you know, we'll share them with our viewers. That's brilliant. Thank you so much.
Awesome. Well, thank you very much for having me. Thank you.
All right.